Good evening, viewers, and thank you all for attending today's webinar organized by the African Society of Regional Anesthesia. As on the flyer indicated, today's webinar will be focusing on regional anesthesia for lower limb amputation. It's a very important topic, more especially for us in the low and middle income countries that are having challenges on the different alternatives of managing patients that are undergoing amputation. My name is Dr. Ali Uba. I'm an anesthesiologist and the country's ambassador for African Society of Regional Anesthesia. Presently, I practice here in the Gambia, West African country, the smallest country in mainland Africa, as you may know. And I work in a teaching hospital, that early teaching hospital, and is where we do most of the amputations. As of now, we have challenges with the approaches on the management of these cases, and I deem it necessary to bring up this topic, which is what are the options for these patients that are undergoing lower limb amputation. Most of these patients are under many comorbidities and they are having many complications. And the options that we have in our setting mostly is neuraxial blocks, that is specifically spinal anesthesia, which is 90% of cases, and a few of them under general anesthesia. And unfortunately, the prognosis of these patients are not very good. So having an expert today that we invite to the African Society of Regional Anesthesia webinar, that is Dr. Bhaskar Manikam. He's a consultant anesthetist and is a renowned regional anesthesia specialist and fellow in regional anesthesia. And he will be here today to discuss on topics that, a topic that is very essential for us in our practice. Before we start with Dr. Pascal, it's a good reminder that the African Society of Regional Anesthesia will be present in the All Africa Anesthesia Congress in Kigali. That will be next 19 days, where there will be conferences and workshops based on hands-on practice of regional anesthesia and introductions on ultrasound and management and needling for anesthesiologists and anesthetic students in Kigali. So we hope to see you in Kigali in next 10 days. Now we have Dr. Bhaskar Manikam for the presentation of today's topic.
Hello, welcome you all to this live webinar session on Sunday, the 28th of August. I think you will be seeing a recorded session of this. Thank you for joining the session. I'd like to thank Mo for inviting me to give this talk. So today we're going to go through some of the basic theory behind regional anesthesia for lower limb amputation. It's nice to see the African Society of Regional Anesthesia doing lots of webinars for education. It's a good thing that I get a chance to be part of it as well. So hope you enjoy this short session of 20 minutes approximately. We'll go through some background and then tone down to the actual regional anesthesia bit. My name is Bhaskar Manikam. I'm a consultant anesthetist at Darlington and Durham Trust, which is in the north of England. My Twitter ID is down there on the slide. If you would like to ask me direct questions, you can message me and I will be happy to answer your queries. So The major amputation in UK, I'm going to talk mainly from a UK perspective, so I hope that you will be able to translate some of this to where you practice. So it's quite a common problem here, although we don't see it in every hospital because most of these patients go to specific vascular centers. But the incidence is roughly about 1 in 5 for patients who are about 60 years do have this problem, out of which about 1 to 2% need amputation. Um, so the incidence is very high in diabetic patients, and the mortality is high too, for obvious reasons, because they do have multiple comorbidities from diabetes affecting kidneys, heart, and everything else. A lot of these patients do have a revascularization procedure, which is all endovascular done by interventional radiologists and some partly combined with vascular surgeons. Quite a lot of procedures are done to restore vascularity back, but still around 4,000 amputations happen every year in England. So the mortality in this group was really high 10 years back, and that led to being looked at from a national level, that you need to do some quality improvement work to improve the mortality. So they set out some recommendations, which we will see in the next slide. And even after that, they found in 2014, when they looked at the report of all this data that is submitted, their 30-day postoperative mortality was still around 12.4%. So they set out to develop more recommendations, and they insisted that all hospitals should provide data to the National Vascular Registry, which is specifically looking other than aneurysm repairs and other things that goes on, specifically looked at major amputations as part of the vascular registry submissions. So that produces an annual report every year. Uh, so the recommendations, if you look at, which are a good starting point, they said that every hospital providing an amputation service should have a best practice pathway that is designed to look after these patients. And they should not be undertaken in every single hospital. Only arterial centers, which are big centers, which have got all the multidisciplinary team available, and they should submit their data to the National Vascular Registry. This was the beginning of the quality improvement work. And then later on, they added quite a lot of things, that you need to develop a protocol for patient transfer. If they do end up in smaller hospitals, then you need to get the multidisciplinary team involved both before and after surgery. If there are patients who are end of life, which means they are going to die anyway, then they need to be recognized and they need to be managed appropriately. And one of the key things, there were problems that were happening, was that these patients were ending up in emergency lists. There were delays to operation. They were not given priority. So the national body put out recommendations that these patients should be operated on elective lists. So there is no delay. And they should get, the important thing for us is that they should involve the pain and control team and the anesthetists and diabetologists right from the beginning. And they should be reviewed by a consultant vascular surgeon within 12 hours of being admitted into the hospital. So all of this is to speed up the management of amputations, and also to give a better quality of care throughout, both before and after, in terms of rehab and discharge. So we're mainly looking at major amputations. When I say major amputations, it's all above ankle. Anything on the toe, forefoot is minor, and that can be done in any hospital. So their goal was to reduce the 90-day, not the 30-day, 90-day mortality, which is currently around 20 to 30%, to reduce to 10%. So that was the goal. And quite a lot of it has been achieved since this 2014 report came. and we will look at the data that has been submitted into the vascular registry. The right side is the last one, which is submitted in 2021, which is looking at 2020 data. And still there is about roughly, if you look here, there are about 3,200 amputations submitted for that year, despite the COVID. But probably it's around 4,000 now. And there is equal number of above and below knee amputations, although the aim is to reduce the amount of above knee amputations, because that is the group, the above knee amputation group is the one which has got high mortality, around 9 to 10%, whereas the below knee amputations have got a lower mortality of 4 to 5%. So the key, another thing to note is that there are a few risk factors that is very obvious. That 76% of them were male, they were current or ex-smokers, they were diabetic, and they were older than 65. So this is a high-risk group that ends up having an amputation. So this report is produced every year and produced individually for the centers which do this, so they can compare the result with other centers and see how they're doing in comparison to the peers. So the main goal of the best practice is to reduce pain and to provide an optimal prosthetic potential so they can have a prosthetic and be mobilized again. The second thing is to reduce the risk factors, cardiovascular, diabetes, smoking, and to allow supervised exercise therapy in the early stages so they can be avoided ending up having an amputation. And if they do end up having an end-stage problem where there is a complete blockage, then revascularization is the first treatment option. So if they can revascularize, they will do interventional procedures to restore the circulation. If they can't, then they end up having an amputation. And when they do the amputation, they try and do below knee amputation preferably, because that has produced better outcomes. And if they do present really late and they have lots of other problems and they are really in the end stage of their life, then they have to be treated differently and they have managed by the palliative care team. The reason why in UK it moved after 2014, it moved on to bigger centers. This work, which was done in every single hospital, moved on to bigger vascular centers. Is it requires quite a big team to look after. Starts with an amputation coordinator who coordinates all these different specialist teams: psychologists, radiologists, anesthetists, diabetologists, physicians, physiotherapy, rehab, vascular surgeons, limb fitting service, occupational therapists. All of these people are needed to give them the best outcome. So it is done in few centers, one in each region, for example. So, and any other hospital receiving these patients should ideally speak to the respective team and transfer them as quickly as they can. So what is the key role of anesthetist in this is that not only the anesthetic management, of course, anesthetic management is important, but also in pain control, right from the time they get admitted to the time they get discharged. Regional anesthesia is a core skill if you're involved in managing this patient group, because it provides the best optimal outcome. It reduces the risk of anesthetic complications with general anesthetic, for example. And it allows better management of diabetes, fluid control, blood pressure, nutritional balance, because they avoid being sick with lots of morphine, general anesthetic, drowsiness. So it allows them to get the best pain control, minimize opioids, and allow them to mobilize quicker, which prevents so many complications that can result in death and mortality. That is mortality. The most common complications can happen is respiratory infections, pressure sores, DVT, falls, nutritionally depleted, get septic, and they die. So regional anesthesia can in a way, avoid quite a lot of this. So it's an indirectly it influences the outcome and reduces the length of stay. So that's why regional anesthesia is a core important skill if you're managing these patients. Not only regional anesthesia is important, but other things are important as well. So you need a good physician team looking after the cardiac side of things, managing the arrhythmias, the respiration, anemia, blood glucose, nutritional side of things. You need a good team to look on the drugs, multiple drugs they're taking, how to optimize them when they're admitted. So you give a better chance for us to do the regional anesthesia, which combined together gives a better outcome. So from our point of view, we are interested in two things. One is pain management, where we have to do a risk assessment. These patients have multiple history of amputations. They're quite distressed with pain all the time and chronic pain medications. So they need good pain management, which will need to initiate early nerve blocks, which we'll come into in the next few slides. How to get the chronic pain medications continued and use breakthrough painkillers, start multimodal analgesia on top of it, so it gives a balanced effect. And also to plan the anticoagulation as well, so to give enough time, window period to allow you to do a spinal anesthetic if that's your preferred choice. Uh, most of us would prefer to and they work very effectively, but sometimes these patients they don't do very well under a spinal anesthetic because of anticoagulation, risk of spinal hematoma. They could be septic and they have impaired heart function, heart failure, and the blood pressure may be unstable. So it's difficult to manage them under spinal anesthetic. So it's very entirely reasonable to do them all under regional anesthesia, which is apart from spinal, to do it under nerve blocks. It's much safer. Once you learn the techniques, it's pretty straightforward and it provides an optimal, not only anesthetic, gives you options to give the better pain control before and after surgery. So for above knee amputations, the recommended standard is to use a combination of 4 blocks, which is the fossil, which is the F for femoral, O for obturator, S for sciatic, and L for lateral femoral cutaneous nerve. So you combine all these 4 blocks. So you calculate the total local anesthetic dose that's appropriate for that patient's weight. So roughly say 30 to 40 mLs. So we use in UK we use a mixture of ropivacaine and 2% lignocaine with adrenaline, which is a mixture of 2 drugs, both taken to their maximum dose. So although it's at the maximum dose, it's still proven to be safe, and many centers use these techniques. So you divide that total dose into these 4 blocks. So use appropriate volume of local anesthetic for each of them to give a good anesthetic. You can do that, some of this before surgery as a femoral catheter or a sciatic catheter, or if you can't provide that kind of service, at least you can do a femoral catheter for pain relief and do the other blocks just before surgery, so give a good anesthetic and continue the femoral catheter post-op, and you can add a sciatic catheter as well, which can be inserted by the surgeons at the end of the procedure, because they do cut the sciatic nerve for above knee amputation, so they can insert a catheter around the sheath, so you can run a continuous infusion technique or intermittent bolus. If you have pumps, you can run an infusion-based technique. If you don't, you can still put a catheter and give intermittent boluses as and when you need, depending upon how much pain the patient has. So this is a good option to do for above knee amputation. We may have to combine with sedation just in case the blocks don't give you complete coverage, which they do most of the time. Sometimes you may have other nerves that may have partially blocked or not fully blocked. So combining with sedation gives you a good overall effect. For Sometimes if the sciatic nerve is difficult to block them at the gluteal level, which you need because you need to block the posterior thickness nerve of thigh as well. So you need to do it higher up in the gluteal region, which can be a little bit tricky if they've got difficult to turn them on the back, or they're quite big, or they've got some pressure sore or infection. So then there is an option to do an anterior sciatic approach as well, where you can scan from the front of the thigh and scan below the groin, uh, uh, below the level of lesser trochanter, where the lesser trochanter no longer obliterates the sciatic nerve, so you can see through the quadriceps muscle straight into the sciatic nerve just beneath the electromagnetic muscle. You can see them in the uh, both transverse view, which will be seen as a small circular structure like this, or you can keep the probe longitudinal where you will see the sciatic nerve like a rope under the electromagnets. So you can do the block out of plane or in plane by depositing the local along the sciatic nerve. This is an option to do if posterior approach is not feasible. For the below knee amputation, you don't need to do 4 blocks because below knee only the sciatic and the saphenous that are the only nerves that supply below the knee. So you can reliably block them by doing a sciatic nerve just above the popliteal fossa, which we will discuss in the scanning session after this presentation. And the leg can be put up in a support, and you can scan from behind the popliteal fossa, and you can do an in-plane where the nerve structures are very superficial. So you can see the common peroneal and tibial, which are the divisions of the sciatic nerve, and you can place the needle in the middle and have a good spread of local around both the nerves, which makes it work faster. And the saphenous nerve can be blocked in direct canal, which we will again show you in the scanning session. If that is not feasible, you can do a femoral block as well. There's nothing wrong in that. Ideally, we should be placing a catheter or doing before, even well before surgery, for pain control, which gives them a good option for good pain management before surgery, right from the time of admission. You can top it up for surgery and do the operation as well, and then continue with low concentration local anesthetic for post-operative pain relief. So it's a very good technique. As soon as they get admitted, you can bring them into theater, put dual catheters, and run them low concentration and top them up with stronger concentration for surgery and continue post-operatively, which is the ideal gold standard for managing below knee amputation. We use an ambit pump, and these kits are available, and there are several different types of pumps depending on which hospital you go to, and they provide you the option and less nursing care, so the pump automatically delivers the local anesthetic without you manually trying to give top-ups. It is a good idea to continue the pain management post-operatively for a couple of days until the pain eases off, and you take over the catheters, step them down to multimodal analgesia. We use a combination of gabapentin, amitriptyline, tramadol, ketamine, all in small doses in combinations, so that you can control the neuropathic pain, which is not surgical pain, but from the cutting the nerve itself can cause neuropathic pain, so it controls that pain as well. And to a certain extent, it can alleviate the incidence of phantom limb pain. So it's important to, even if you're giving a general anesthetic or a spinal anesthetic, to use these nerve block techniques for post-operative pain relief at least. But ideally, the pre-operative pain relief is equally important. So the reports, all of the reports this is from 2014 report. I'm sure in UK things would have improved since all these recommendations have come and the centers are implementing as per the recommendations. But it is quite sad to see that the 2014 report, which was only 6-7 years back, that pain was one of the common problems, and was not optimal pain management was not consistently provided. I think it depends on the centers and the skill mix and the competence of the anesthetist in able to provide this sort of continuous nerve catheters. The reason why pain management is so important is it just stops limits the ability of the therapy teams to come on rehab, and they doesn't give the patient good experience or and allow them to mobilize early and reduce the length of stay. So we have an important role to play, and regional anesthesia is a core skill that if you develop the skill, you will be able to provide the best pain management, which is key component in giving better outcome for this patient and reduce the mortality. So that's all I have to say about in this introduction why we're talking about lower limb amputation and why regional anesthesia is so important in this particular patient group. I hope you enjoyed this little session, and we will do some scanning. So if you have questions, we will have time to discuss at the end. And if you do have specific queries, you can send me by the Twitter as a direct message, and I will try my best to reply to your queries. Thank you for joining today. I hope you have a nice evening, and thanks for this opportunity.
Thank you very much, Dr. Bhaskar Manikam. What an excellent presentation. I was keenly listening to every slide that you have gone through. And I'm very sure there are very many questions and doubts that people would like to ask. But before we go into questions and answers, if you have questions, there's a question for questions and answers where you can write your questions. And Dr. Bhaskar will be here to answer those questions. And from now on, we'll have a presentation, a live scan on the popliteal nerve block. Let's see what Dr. Bhaskar have for us there. Thank you.
We're going to look at popliteal sciatic block for this session. Again, I'm going to use a high-frequency linear probe. The patient is, here we have got a model here, Carly. So he's kindly agreed to do this session with us, and he's positioned prone. So you could do this block both prone, lateral, or supine. So here, for the sake of this demonstration, we're going to do the prone positioning. So he's positioned prone, and I've got a kind of linear frequency probe. And I'm going to orient myself, which is lateral, which is medial. So the left side of the screen is lateral, and the right side of the screen is medial. So you place the probe totally perpendicular in the middle of the popliteal fossa. And what I'm looking there is some kind of a vascular structure and nerve sitting on top. Again, there is a lot of anisotropy because of the way this popliteal fossa dips down and then rises up. So generally speaking, if you tilt your probe towards the feet, you get a better visualization of the nerve. Because of the anisotropy, the ultrasound beam has to be exactly perpendicular to the nerve. So what are the key landmarks here? I'm going to, generally the popliteal sciatic nerve is on the lateral side of the popliteal fossa. So I'm placing my probe on the lateral side. I'm looking for the popliteal artery, which is this big circular structure. The vein is a collapsible structure, as you can see from the screen. As I press hard, the vein completely collapses. And as I release it, it just kind of comes up again. On top of the vein is the sciatic nerve. It is very, very close there at that point. Now the next step you need to do is just to kind of trace the nerve proximally and distally to find out whether that is actually the full sciatic nerve or is it just the one component of it. So I'm going to trace it. So you see that now there's two nerves there, both sitting next to each other. As I go distally, they kind of separate away from each other. The one that goes away from the popliteal vessels or the common peroneal nerve, the one that stays with the popliteal vessel is the tibial nerve. So I just go back to the point where it bifurcates, and if I move his feet, just let me have some more chill. So if I move his feet up and down, So just let me relax. I'll do it for you. So if I just kind of lift it up, down, so you kind of see this kind of seesaw movement of both these nerves kind of rubbing against each other. So the idea is to kind of find the bifurcation and do the block at the level of the bifurcation. So if you're doing it in prone position, so you place the nerve at the level of the bifurcation. So because your end point is to get in between the two nerves inside the paraneural sheath. So I'm going to come from the lateral side. You see where my finger is pushing against the biceps muscle. So I'm going to come through the biceps muscle, totally perpendicular. And so you will see a straight line of the needle coming through and getting in between the two nerves to block them. Some key points to note: if you're not seeing it straight away, do a little bit of a tilting motion just to see whether it shows up as bright echogenic structures. And usually you see the biceps muscle on top, the long and short head of the biceps, and on the medial side you will have the semimembranosus and the semitendinosus muscle. So in between them, just sandwiched between these two group of muscles, you will see the nerve. You always look for the popliteal vessels. You need to know exactly where they are before you do this block, so you don't want to accidentally inject intravenously into the popliteal vein. So that's the key points for this nerve. So we're going to move on to the ankle blocks. So Curly, do you mind turning on your back? So we're going to look at the ankle blocks now. So the main nerve to block in the ankle nerves is the posterior tibial nerve. That can be identified just medial to the medial malleolus. Again, probe orientation. The left side of the screen is anterior and the right side is posterior. So I'm going to go slide my probe at the level of the medial malleolus. I'm just going to look for the kind of lots of tendons there. You see this bright echogenic things which appear like nerve, but they're actually the tendons. And then you see the posterior tibial artery and a couple of veins around it. So if you scan behind the kind of posterior tibial vessel, then you see like kind of a triangular structure there sitting. You can trace them both proximal, distally. It's got a very white echogenic architecture. As you scan proximally, you can see it is going next to the posterior tibial vessels. So I'm going to find a clear fascial demarcation around the nerve. So when I'm happy with that, so you see that triangular structure. So I'm going to target, like I do an out of plane approach, targeting the pointed end of, see my finger pressing. So I choose my entry point there. So I'm going to aim for that tip of the triangle so that you're not injecting intraneurally, but at the same time you're not trying to target the base of the triangle where it could be going straight to your posterior tibial vessels. So you're trying to aim for the tip of the triangle. And because it is enclosed within the fascial layer, the local anesthetic spreads very nicely. And you need about 5 to 10 mils of local anesthetic to block this. You see, this is as big, almost 2/3 the size of the sciatic nerve, because this is the main component of the sciatic nerve, and it supplies the whole of the sole of the foot, all the osteotomes. So this is a very important nerve to block for foot surgery. Okay, so moving on from the medial side, you come to the anterior side. So the next nerve you're looking for is, so we're doing all these blocks above the level of the above the level of the malleolus. So you do the posterior tibial, then we're going to go for the deep peroneal nerve. So there you place your probe exactly on the tibia. So you look for the clear tibial outline there. So you see the bone nicely. On top of it is your dorsalis pedis artery, which is very nicely pulsating. And on the side of the artery, you have the deep peroneal nerve. So if I just kind of trace this artery up, you see that nerve is trying to climb over. So I'm just going to keep it like that. So just kind of climb over the artery. So I'll do this very slowly again at the nice tilt. So you see that it is trying to climb over it. and just kind of slides over the artery and comes to one side. Yeah, see, it's just trying to climb over and come to the other side. So you could block it on either side of the artery, and you will get a nice local anesthetic spread. Again, 2 to 3 mils is enough. It's a very small nerve. You see, compared to the posterior tibial we saw earlier, this is a very tiny nerve. And you have to make sure you're not injecting under the periosteum. So you have to, if you hit the bone, just withdraw the needle and you just have to gently inject 2 to 3 mils. So the next nerve as you move further is that, if I ask Carly, can you bend your knee? Is that because the next nerve is a sural nerve. It is behind the lateral malleolus. So it is useful to have the foot resting down so you can access the saphenous nerve clearly. So here again, you see I'm going above the lateral malleolus, but more posteriorly. See, the left of the screen is more posterior, and the right of the screen, where I'm pressing my finger, is anterior. And you see like the little kind of behind between the tendon Achilles and the muscle here in the front. So you have a little hammock, and in this hammock lies the sural nerve. The sural nerve lies alongside the short saphenous vein. So there's a clear fascial hammock there. Hammock is like kind of where you just kind of, when you swing between the trees, so that kind of the fascial lining is there. And what it has within that little pocket is your sural nerve and your short saphenous vein. So it's very easily can be blocked again with the out of plane technique. Just put 2 to 3 mils. So if you're holding a probe, so insert your needle there and inject 2 to 3 mils of local anesthetic. So you could move the probe thing away. So you're injecting it. So I'm putting my finger just on top of the nerve, and you just inject 2 to 3 mils. So 3 nerves done. Now the another nerve that we need to block is the superficial peroneal nerve that supplies the whole of the dorsum of the foot. The posterior tibial supplies the sole, whereas the superficial peroneal nerve supplies the dorsum of the foot. The sural that we saw just now supplies just the lateral border and the fifth toe, and the deep peroneal, which was the tiny one next to the dorsalis pedis, just the first cleft. So it's mainly useful for the first toe and the second toe surgery. So the superficial peroneal nerve, unlike the other nerves, you do them slightly higher up above the ankle. So on the lateral side, so again orientation, left side is posterior and the right side is anterior. So you look for the fibula. The fibula is this bone there, which is very small, and the tibia is this big bone there on either side. So if you look at the fibula, where the fibula ends, that's where it kind of draws up that fascial line, kind of draws up to where your superficial peroneal nerve is. So if you carefully look in the groove of the muscles between the two, see, I'm going to go all the way down where the fibula ends. Okay, so you see the pointed end of the fibula. The pointed end of the fibula is going to point at where the superficial peroneal nerve is. If I keep tracking it proximally and follow that groove, you will see that the superficial peroneal nerve lies in that groove, and at some point you will see it very nicely. Okay, so there. Okay, so there is the best place to block. So usually it accompanies by a little vessel. You see that pulsating there in that groove? So you just track it down when you can see the nerve clearly. Again, this can be done with an out of plane technique. So in this case, so you could do it from above or below the probe. So I see where my finger is. Yeah, where my finger is pressing. So that is where the superficial peroneal nerves. Again, 2 to 3 mils is enough. So we have seen 4 nerves, and these are the 4 main nerves that supply the forefoot. If you really want to cover the other nerve, which supplies a little bit of the medial malleolus area, then that's the saphenous nerve. It accompanies the long saphenous vein. So if you identify the long saphenous vein, then you can see the nerve. So we're going to look for the long saphenous vein. You see that big vein there, just over the tibia. So on either side, you see some kind of a nerve-like structure. It's very difficult to see in some. I think in him it is very clear and easily collapsible. So a simple perivenous infiltration around there So you can do it in plane because there's no tendons there. You see this? If you approach the needle from there and you just enter into the pocket where the long saphenous vein is, then you can do a perivenous infiltration that will cover the saphenous nerve. This is just to make it totally complete. You don't need to do all 5 blocks for surgery depending on the location. If it's a big toe surgery, then you need to do 3, and if it is 3 for 3 toes or all 5 toes, then you may have to block all of them. So that is in a sense the ankle block. Both have different indications. Ankle blocks are generally done for forefoot surgery, whereas oblique sciatic block for any surgery below the leg, the lower leg, ankle, and foot as well.
Wow. Thank you very much, Dr. Bhaskar, for that live scanning. And it's interesting to see how many options we have in peripheral nerve blocks. And I think it's essential that we have a first-hand idea on that we have options on not only intraoperative management of pain, but also on post-operative management. Most of us are more acquainted with upper limb blocks, more especially those of us who are not regional anesthesia specialists. So when it comes to lower limb blocks, we have so many nerves that are needed to be blocked, unlike when it's upper limb. So it becomes somehow complicated to as a starter, to have a clue or a clear idea on the steps or the tips on which we need to do to have a successful block. I think that's the objective of everyone. I will urge the audience, if they have questions, they can write it down. I myself, I have a few questions that I want some clarifications. The first one is the fossil block. You mentioned if you need a upper limb amputation, the blocks that are ideal are the fossil block. That means you need to block 4 different nerves. And in such a scenario, do we use it as a sole technique, or you have to combine it with a neuroaxial block?
You can use it as a sole technique, and that's why that's what I think would be the ideal option. When you can't really do the blocks as a sole technique, it's purely because the anesthetist may not have the expertise to confidently do the 4 blocks to give a complete anesthetic, but that's purely a training issue. Once you learn how to do the blocks and you do a few of them, you will get really comfortable. Then you won't feel the need to combine a spinal anesthetic as well. To start off with, I would suggest that if you're comfortable doing it under spinal, then do it, but add the nerve blocks as well. So it allows you to get through the learning experience about doing these blocks. But as you get really trained in doing the blocks, then you will feel that the need for a spinal is no longer there. The nerve block will be sufficient enough for the operation.
Okay. So as you're saying, for in case you use it as a sole technique, do these patients really need a level of sedation? Because in our experience with upper limb blocks, good number of the patients don't need any level of sedation. But with respect to lower limb blocks, more especially the fossil on above knee amputation, do we still need to put them on a level of sedations before we consider it as an ideal technique?
Yeah, the sedation is actually, I wouldn't say it is mandatory. It is mainly because the sciatic nerve block sometimes takes longer to work. If you do a gluteal sciatic block, the onset time of the sciatic block itself is half an hour minimum. So if you're comparing it to an upper limb block, upper limb blocks work much quicker. So you don't really have to wait longer. So whereas here, you really need to do the block well in advance of the operation, because sometimes they can take a while to work because it's quite a thick nerve, it's a big nerve. So the sedation is mainly from a comfort point of view. If you want to avoid it, you can avoid it. Say, for example, if you're running a catheter based technique preoperatively, then there will be already an existing block. All you're doing is a top up just to make it strong enough for the surgery.
So those kind of situations, it would be ideal. It's like, treat them like how you manage a labor epidural for a cesarean section. So if you're running a good labor epidural, if you do a top up, it works very well for the section. The same way, if you run a good pre-op catheter for before amputation, then you should be able to top it up and use it for the operation as well.
Okay, that's good. I'm still waiting on questions from the public, but I have one more question with the popliteal fossa block. As you were scanning, if you are going more proximally, you have it as one fascia. All the nerve comes in one fascia, but as you scan low, downward distally, you have the common perineal and the tibial separating. So with your experience, at what level do you usually block this case, the sciatic at level of the popliteal? Is it before bifurcation or when they already divide?
For the it depends on the purpose. Like, for example, if for the below knee amputations, you really need to, you're doing the block at the popliteal fossa. So for example, when you're doing it at the popliteal fossa, it makes sense to do them at the level of the division, because you're injecting into the sheath where you see how thick those nerves were. So by injecting it at the level of where it's splitting, you basically make the anesthetic to work quicker, so that they spread nicely around both common peroneal and tibial, and you will find the onset is quite accelerated. But whereas when you're doing it when the sciatic nerve is in one big nerve with a before division, it's sometimes you're not quite sure whether injecting intraneurally in the sheath, whereas here the sheath, paraneural sheath, is very clear, and you can completely avoid injecting intraneurally into either the common peroneal and tibial. The advantage is purely from an onset time point of view, but you can do the block at any level along the sciatic nerve. It's absolutely fine.
Okay. In a scenario like our settings, we usually have problems with catheters. Mostly we have only the needles. So we have only one shot that we have. So in such scenarios, what volumes and concentration will you recommend us to do, more specifically when it is below knee amputation?
You have to use the highest concentration available, because if you're using it purely from surgery to provide anesthetic, but if you're combining it with spinal anesthetic, then you really don't need to use high concentration. You can use lower concentration as well. But I would recommend you to try using nerve block as your primary anesthetic, and it should work very well if you use a higher concentration local anesthetic. It might need some extra time for the block to work, but that is something that can be planned because the advantages are there in terms of avoiding the problems with spinal anesthetics. So 0.5%, is 0.5% of bupivacaine available for you over there?
Yes.
Yes. So 0.5% is for surgical block. If you're using it for purely from a pain relief point of view, then 0.25% chirocaine or bupivacaine would be sufficient for all of the blocks.
And in case of for the popliteal, there's a question that says, when you prefer ankle block, do you prefer ankle block over popliteal sciatic amputation, and what is the preference?
Oh yes, so for the ankle block is something that we use mainly for toe amputations. So the ankle block would be sufficient for a toe amputation, but if you're doing it like at the ankle amputation, like quite something below knee amputation, then you would need a popliteal sciatic block. So it depends on what is the operation that the surgeons are planning. You have to do them proximal to that level. So ideally we do, I mean, all hospitals in UK do toe amputations, and
for foot amputations. So those can be easily done under an ankle block, because ankle blocks are quick onset. They work very quickly, and compared to a popliteal sciatic block. So we prefer to choose ankle blocks for any simple toe amputations.
One more question from the audience. It says, are there rules for distal femoral nerve branches blocked as analgesia or anesthesia?
Sorry, repeat that question.
The person said, are there rules for distal femoral nerve branches blocked as analgesia or anesthesia?
Distal femoral nerve. I think, are you asking about the saphenous adductor canal block?
I believe he refers to saphenous.
Yes. The adductor canal block, I think in my slide, I said for below knee amputations, you combine the saphenous at the level of adductor canal block with the sciatic, popliteal sciatic. But saphenous nerve is purely a sensory nerve. You don't really need a high concentration local anesthetic to block it. So even a lower concentration local anesthetics should easily block it. So 0.25% quiracaine, it should be enough to block that in the adductor canal, say roughly about 10 to 15 mils. If you want to avoid the local anesthetic dose point of view, for the nerves that are predominantly sensory, for example, lateral femoral cutaneous nerve, the saphenous nerve, they're all purely sensory nerves. So you don't need a high concentration local anesthetics. You can reduce the amount of local anesthetic doses when you do those blocks and reserve the local anesthetic doses for the main motor nerves, which are the femoral and the sciatic.
Another question is in ischemic pain, do the sciatic catheters good? And if they are, how long do you keep them?
Okay, so there is no right or wrong answer for this. If there is not much evidence base for using it for a longer period of time, the sciatic nerve catheters can be placed by anesthetist as well as by the surgeons during the operation. So generally, it depends on the length of the stay and your pain team's ability to run the catheters in the long term. In our hospitals, we generally don't keep catheters for more than 7 to 10 days because of the infection risk. If you're running a sciatic catheter, I would say running it for a longer period of time would be preferable, because unlike other surgeries where the pain is predominantly incisional pain, they do resolve after 48 to 72 hours, whereas in amputations, some of it is neuropathic pain. So if you run a nerve catheter, running it for a longer period of time makes a logical sense. But saying that, there is not much of evidence in terms of preventing chronic pain or phantom limb pain by running catheters for longer periods. So you can run for minimum 3 days, and then start kind of stopping the infusion and making them as and when you need. So you can slowly wean off. If the pain is not an issue, then you don't need to give any more bolus. And if your multimodal analgesia is sufficient, then you can slowly withdraw the local anesthetic based techniques and leave it for another day. And if they're not needing anymore, then you can remove them. 3 days makes sense. But if there is nothing wrong in leaving it for a longer period of time, if the patient benefits from it and they need it for the good pain control.
Okay. From Dr. Tego, said, I prefer abductor canal plus popliteal approach than giving 5 multiple injections at ankle level. What is your thought?
Yes. I totally agree that both of them will be good, and they will give you the same benefit, because both are good regional techniques. We tend to do a popliteal sciatic and an adductor canal block if a surgeon is using a tourniquet below knee to cover the tourniquet pain. as well. But if they are not using a tourniquet, if they're just using some kind of a um, localized tourniquet, or maybe sometimes the vascularity is so bad that they don't even need a tourniquet for these toe amputations. So we do the proximal blocks mainly to cover tourniquet pain, but for simple toe amputations, we find the ankle blocks are quick onset, and they give a reasonable anesthetic, good anesthetic, and very good pain relief. So the patients can be mobilized quicker as well. Whereas popliteal sciatic block will leave them with a foot drop for the next 16 to 24 hours, which can be a little bit uncomfortable for the patient. Whereas ankle block, they completely retain the foot movement. All you're blocking is just below the level of ankle. They have retained the full motor function.
And the next question: if in a scenario there is only lidocaine available for popliteal blocks, what concentration will you prefer?
Again, the question is depends on whether you want to give an anesthetic block or an analgesic block. And when I say anesthetic block, it's for doing the operation. For doing the operation, I think you need at least more than 1%. So because you want to give a good motor block as well. So when I say motor block, you need a dense block, not just a very light block. So 1.5 to 2% would be required for a surgical block, and maybe 0.5 to 1% would be sufficient for doing as mainly for pain relief perspective. But it won't last longer if you're using lignocaine. So I wouldn't really recommend you to use lignocaine from a post-operative pain relief point of view, because the blocks will wear off very, very quickly. If you're using it mainly for an operation, quick operation, then if that is the only local anesthetic available, yes, you can. But ideally, when you are using nerve block techniques, it's preferable to use longer acting ones, so it provides some extra duration of pain relief as well.
Okay, and for the last question, what or which patient will you not recommend for peripheral nerve blocks that is undergoing amputation?
If the patients are, I have to think about, if the patients are really uncooperative or having you find it difficult to get the consent for this type of procedure, then it becomes quite tricky, because there's quite a lot of blocks you need to do. It is time consuming for each of the blocks. So I wouldn't say that as a contraindication. That needs, the whole team needs to explain the benefits, including the surgeon yourself. So it's all a team effort that you see why it's beneficial for the patient. The contraindication as such is not there. It's all relative contraindications. So if there is a localized infection, then you don't want to do the block at that level. So you have to choose a different level to do the block. Obviously, using ultrasound improves the safety. So if you're near a blood vessel, then you don't want to cause a hematoma there. So you need the experience and the ability to visualize and use ultrasound, and to avoid that vascular puncture related problems. But I don't see any other contraindication as such. In fact, all other types of anesthetic have got more contraindications than regional based techniques. So the nerve blocks is an option for patients where there are loads of other contraindications, and this is the only way you can give them the anesthetic to make sure that they get an early surgery. So even if there are relative contraindications, there are ways to overcome that. So if I think of anything else, I will let you know. But at the moment, I can't think of any absolute contraindication for a nerve block other than patient being uncooperative.
Okay, thank you very much, Dr. Bhaskar. It's a great pleasure having you, and it was an excellent presentation. And it's an opportunity for us, more especially young anesthetists that are growing in with great interest in regional anesthesia. And on behalf of the African Society of Regional Anesthesia, we say big thank you. And the Gambian anesthetists who are also listening say big thanks to you. And we will update you on our progress with lower limb blocks that we will hopefully initiate very soon, and we'll give you feedback on how we are progressing. And thank you very much, and all of you who have been viewing us and listening to these lectures. Thank you. And those of you who I cannot answer the questions, you can follow us on Twitter, and we'll update you on our next webinars, which we will be having on trimester. For notwithstanding, you can follow us on our Kigali conference that we will have live scannings, presentations, and workshop on regional anesthesia. Thank you very much, Dr. Bhaskar.
Thank you. Thank you. It's nice to be with you all. Bye.
Bye.
Thank you.